Okay, it's a real pleasure and honour for me to be here. Oops, I maybe shouldn't have touched that. It's a real pleasure and honour for me to be here at this launch meeting of FRAX and the guidelines. I guess I've got to take control here, is that right? I guess. Let's just fire up a second.
Λέει να το έλεγε αυτός.
So while we're getting the technical problems sorted out, as I say, this is a culmination of work between the University of Sheffield and Professor Lau-Reitis and his colleagues in ΕΛ.Ι.ΟΣ. And I'd really like to pay a great tribute to Professor Lau-Reitis and his colleagues, to Amgen, to GSK, for the work that we've been able to undertake over the last 6 months or so to move from a situation where we didn't have a FRAX tool for Greece to producing a FRAX tool for Greece in a fairly timely fashion. And what I want to do this evening is just to give you a bit of background to FRAX itself. FRAX will be familiar to many of you, but just for those of you who are maybe hearing the story for the first time, just a little bit of background. And then, most importantly, to carry on and see how we can apply FRAX in the clinical situation. And that will lead us on very nicely into the discussion of the clinical guideline. That's great. Clinical guideline that is also being launched. Thank you very much. Thank you very much for technical assistance. So what we're going to talk about is FRAX. But of course, as clinicians, and I guess most of us in the audience are clinicians, the aim of treating osteoporosis is to decrease the burden of osteoporosis. And the burden of osteoporosis is fractures. That's what causes the morbidity to patients. That's what causes the cost to society and to the individual. And what we want to do is to reduce that. And we're in the very fortunate position of having access to a greater number of highly effective therapies that can decrease the risk of fracture. The key is in who do we treat. How do we identify those individuals who are the highest risk of fracture so that we can initiate treatment with the effective therapies that we've got. So, to be able to identify risk, and not only to identify it, but to quantify it, so that we can say to our patients, this is your risk. And that's helpful because we're going to say to the patient, we want you to take some treatments, not just for the next week or the next 2 weeks, but perhaps for the next few years and beyond. And to do that, it helps for them to understand their risk as well, because that can influence their behavior. So, FRAX was a tool that we started thinking about back in the middle 1990s, about 15, 16 years ago. And what we wanted to do was to develop a tool that would bring together risk factors into a neatly applied clinical tool. And those risk factors should have global applicability. So this tool should be able to be used in Greece, it should be able to be used in Japan, North America, South America, Australasia, and so on. So we had to get access to cohorts from around the world with individual risk factors within them. And we asked the question, which risk factors predict fracture? And do those risk factors behave in the same way in Greece as they do in Japan, America, and so on? So that was the first part of the exercise, to get access to this data, put together a large cohort of approximately 50,000 individuals, and to start to look at how the risk factors performed, And not only how the individual risk factors performed, but how they interacted with each other, so that you could adjust each risk factor for how the other one was influencing risk. And we came up with a number of risk factors that many of you will be familiar with and we'll look at on the slide in a second or two. So the good news is that the risk factors that we've got in FRAX behave pretty similarly around the world. And the one that I always use as an example is prior fracture. So prior fracture roughly doubles your risk of future fracture. And it doubles your risk of fracture whether you're working in Greece or whether you're working in Australia or North America. But the question is, doubles it from what to what? Because some countries have the fortunate situation where they have a very low incidence of fractures, and others have a much higher incidence of fractures. So just saying to someone, we've doubled your risk having had a prior fracture, doesn't actually tell the whole story. You need to say, doubled it from what to what. And to do that, we need the second stage of the development of FRAX, and that's the epidemiology of fracture within the particular country for which you're building a model. And that's really the exercise that Professor Myretis and ΕΛ.Ι.ΟΣ and Amgen GSK have been helping us with since about August last year, to get access to good epidemiological data for hip fracture. And then from that, we can extrapolate the epidemiology of other fractures and help us to build the FRAX model for Greece. The other important thing is that the output of FRAX is not just the risk of fracture, it's a probability of fracture. And the probability and risk are two slightly different things. When you're younger, your probability and risk are essentially the same thing. But probability takes into account your risk of dying. So when you're young, your risk of death is low, and that doesn't really influence the fracture risk assessment. But as we get older, then at extreme old age, actually our risk of fracture may be really high, but our risk of dying is even higher. And your probability of fracture starts to decrease at the extremes of age. And so FRAX is different from the other tools. It takes that into account. The other example of that is smoking. Smoking is a risk factor within FRAX. Smoking, if you look at most of the epidemiological studies that have looked at the relationship between smoking and hip fracture risk, smoking decreases your risk of hip fracture by about 20%. So should we be encouraging all our patients to smoke? Well, smoking protects you against hip fracture by killing you before you live long enough to break your hip. So again, FRAX takes that into consideration. So this is FRAX version 3.6 that we launched at the end of April this year, and in version 3.6 we were very pleased to not just have a Greek FRAX tool built on Greek hip fracture epidemiology and mortality data, but also to produce it in the Greek language version so that it was accessible to all. So, and you can see, I'll show you a screenshot of the Greek site in a moment or two. In June of last year, we put a counter onto the website to actually count not visits to the website, because visits we're not that interested in. We're actually interested in calculations. So this counter on the bottom right-hand side of the home screen only goes up by one every time a calculation is done. And you can see that there's about 2.7, 2.8 million calculations each year on the online version of FRAX. Who is FRAX for? Well, in this room there is a combination of experts in osteoporosis and some people who may not be quite so expert but are interested in osteoporosis. And the vast majority of patients at risk of fracture, or even who have already had a fracture, are looked after not by experts, but are looked after by primary care physicians or other physicians whose primary interest is perhaps not osteoporosis. And what we wanted to do was to provide a tool that would bring the expertise of osteoporosis risk assessment and osteoporosis management to that population, where they're often busy, they've got lots of commitments, they've got lots of other diseases that can fill their time, and we wanted a quick, easy assessment that they could undertake to advise patients on their risk and the need to take treatment. So it's not primarily aimed at experts, it's aimed at spreading expert knowledge out into a wider population base. So again, this is the Greek version of FRAX that was launched, as you can see, from about the 25th of April through until last week when I printed this off the screen. There were about 1,700 calculations that have been done in Greece. So going along at perhaps maybe sort of something like 50 to 60 calculations a day in the Greek model. Of course, this doesn't reflect the Greek usage of FRAX, because until you have the Greek model, most of you were using the Italian FRAX model, because the epidemiology was felt to be very similar to that for Greece. And I'll actually show you where Greece sits on the graph of FRAX usage before the launch of Greek FRAX in a moment or two. Where does bone density fit in? Because you can estimate the risk of fracture with FRAX without BMD, and you can estimate the risk of fracture with BMD. And that really depends on the situation in which you find yourself, the healthcare system that you're working within. If you're working within what John Keynes calls the UK in terms of densitometer provision, he calls it a third world country, because we've got very limited access to DEXA equipment, then you need to try and target that resource to a certain segment of the population. Whereas if you work in a situation where there's ready, good, easy access to DEXA, then DEXA becomes just an integral part of the risk assessment. And there's absolutely no doubt that because BMD is an independent risk factor in FRAX, if you've got access to it, then measure it, make it part of the process. And that's really the approach that you'll see in the guidelines. Bone mineral density is a first step in the assessment within those guidelines. And you'll see that on the right-hand side of the slide here, where we've undertaken DEXA scans and FRAX assessment in all 1,000 of these women at the age of 65, you can see that the sensitivity is about 56% for future hip fracture, and the number needed to treat to prevent one hip fracture is about 33. Whereas at the other end, where we haven't used BMD, the sensitivity is somewhat lower, it's only about 30%, and the number needed to treat is about 54. But if you concentrate on the middle rows of the columns of the table, then for scanning about 30 to 40% of the population, we also get a significant benefit in terms of the number needed to treat and sensitivity. And that's the approach that we can take in a country like the UK, where we've got limited access to DEXA, whereas in other countries with good access, DEXA can be undertaken more widely. So BMD enhances FRAX. That's why BMD is in there as an option to improve the prediction of FRAX. It improves case-finding algorithms. But if you're limited resources, and I guess within countries even such as Greece, where you have good access to DEXA, there will still be small pockets, small areas, where there is limited access to DEXA, and then you can start to think about how you might target measurements in that segment of the population. Now, I don't have time tonight to discuss the limitations of FRAX, but as much as a clinical tool for predicting fracture risk and interacting with your patients about the risk assessment, I regard FRAX as an educational tool. And it's a tool that you can bring out and speak to our colleagues who perhaps don't know quite so much, and use that as the starting position of the educational process to talk about osteoporosis. And part of that education is about the limitations of FRAX. Every single algorithm that we produce in medicine or outside medicine has limitations to it. Even guidelines and things where we just make simple decisions on prior fracture or BMD all have limitations to them. So it's important to be aware of those limitations. Some of the most obvious limitations are the things that we don't have in FRAX. And the most common question that we get asked is, why aren't falls in FRAX? And when are falls going to be incorporated into FRAX? And that's something that we really want to try and accommodate. And perhaps with better and larger cohorts coming through, with not just data on falls, but data on falls plus the other FRAX variables, because we want to look at the interaction between falls and all the other risk factors that we already have in there. Once we get that data, then we should be able to update FRAX. But it's not, again, at the bottom of the slide we say, it does not replace your clinical judgment. If you get someone who's at high risk, and let's say you've got a threshold for intervention that is 20% major fracture probability in the next 10 years, and the individual who's sitting in front of you has a major fracture probability of 18.5%, and they're a faller, then our clinical judgment should be saying, actually, that's probably an underestimate, and they are probably over the intervention threshold that we should intervene. There's a lack of detail on some risk factors. Again, we've been addressing that, and for the sake of time tonight, I'm not going to go into that. I'm happy to discuss it at the end. But we are and have published papers on how you might adjust the FRAX probabilities for the dose of glucocorticoids, for example. We're also looking at ways of trying to incorporate not just the prior fracture, but the number of prior fractures. And that's something that, again, as I say, we would like to do. It's not my major pressing need for FRAX at the moment, because people will say to me, the patient who has 4 vertebral fractures has a much higher risk of fracture in the future than the patient with 1 vertebral fracture. Why can't I put 4 fractures into FRAX? Well, to me, you don't need FRAX if someone's got 4 vertebral fractures. They need treatment. They need investigation to exclude the secondary causes, and they need treatment. They don't need a fracture risk algorithm to tell you exactly what their risk is. So, FRAX is only half the story. The clinical application requires the great and the good to get around the table and discuss what to do next. And in Greece, you're actually really ahead of the game. Because in most countries where we produce a FRAX model, they then go away and spend 6 months, a year, 2 years, figuring out how to incorporate FRAX into the guidelines. But you've already got a guideline with FRAX in it, and now you've got a Greek FRAX tool to put into that guideline as well. So you're one step ahead of the OSCE in terms of developing guidelines. So FRAX has been incorporated into a variety of guidelines in the UK, in America, several European countries, Japan, and at the bottom of the table here just this year, we've got the Greek guidelines with FRAX incorporated within it, and you'll hear more about that approach in the final talk. So these are data, and I apologise for all of you that are more than 2 rows back because you can't read the countries on the list here. But this is within the EU 27 countries, and we're looking now at the number of calculations coming from a specific country. We can't say who is doing it, whether it's patients, whether it's GPs, whether it's hospital doctors, but this is just requests that are coming from within a particular country to do a calculation. And at the top of the slide, up here, if I can get the noise to up here, it's not a little bit here. At the top of the slide, we've got the EU 27 average. The highest user of FRAX in Europe, the EU 27, is Belgium. Okay, so huge use of FRAX as a clinical tool in Belgium. The UK is followed closely behind that. And down here we've got Greece. So Greece was using the FRAX tool, it was using the Italian model, and now it's got a Greek model of FRAX. And the question is, how do we now take that, put it out into the community, increase the awareness of it, increase the awareness of osteoporosis, increase the awareness of the treatment guidelines that have just been published, to actually do our patients a bit of a better service in terms of targeting the good treatments to the people who really need them most. How did we do that in the UK? Well, in the UK, what we did was we took the RCP guidelines from 1999, and basically that said that if you had a clinical risk factor, you got a bone density scan done, and if your bone density had a T-score of around -2.5 or less, taking into account other characteristics of the patient, then treatment might be initiated. The only way you could bypass that approach was if you had a prior fracture. And because we had limited access to DEXA, particularly in 1999, the Royal College said, actually, if you've got a prior fracture and you live in the Highlands of Scotland, then your doctor can't say to you, gosh, I think you might have really risk of osteoporosis, but I can't treat you because I can't get a DEXA, so I'm not going to treat you, because that patient's at high risk. So it enfranchised the treatment of people with prior fractures because they're a particularly high risk group. Thank you very much. So what we do now is that we take the clinical risk factors and we undertake an assessment of fracture probability with FRAX, and we divided the results into 3 groups. If you're very low risk, the patient was reassured. If you're very high risk, and the patient with multiple fractures would be a good example, then you could go ahead and treat. And if you were in this intermediate group, then you went through and had a bone density scan and used that to inform your fracture calculation and then make the decision about whether the patient's high or low risk. But that's a strategy that is really built for a country with relatively modest access to bone density. In America, for example, the high and low risk groups don't exist, and a similar approach increased because there's good access to BMD and everybody goes down this pathway, get bone mineral density as part of their assessment, or bone mineral density was the first part of their assessment. What you can do then, and what we've done for primary care in the UK, is to translate that into guidelines. And if you have time and you go onto the FRAX website and you go to the UK model, then when you put the patient in and the numbers come out, you will see a button that appears on the red box in FRAX, and you can say, view NOG guidance. And it takes that individual's result through and plots it on one of these graphs. If you haven't had a bone density done previously, this graph will appear. If you've had a bone density done previously, this graph will appear. And patients, this is the intervention threshold, and I'm not going to spend any time on the intervention threshold. We can maybe come back to it in the discussion. But we're scanning people who lie at or around the intervention threshold with our limited access to DXA resources. And so the GPs, primary care physicians, really like this because it's just a traffic light system. You know, it's a green, you can relax to some extent, give lifestyle advice perhaps. Amber, send off for a bone density scan, and if it's red, you can consider treatment, and that's widely accepted. Why did we take that approach? Well, we took that approach because this is a similar graph, and again, I apologize to those of you behind the 2 front rows, but this is the density of density equivalent across Europe. And here's the average for units per million population in Europe. At the top, we've got Belgium, and in second place, we've got Greece. And the UK is down here. Okay, so that's why we took the approach that we took. We don't have access to bone densitometry in the same way that you have in Greece. We're currently putting together an EU guideline, or at least a proposal for an EU guideline, which is obviously not a hard and fast rule that you must follow. It's a guideline, it's an idea of how you might approach things. But in this setting, you can still take an age-related intervention threshold, which is shown here, that goes up with age. But instead now of having the red area, where we treated some patients without BMD assessment, now essentially those people, people are divided into 2 groups: those who are relatively low risk and don't need a DEXA, and those who are at high risk and do need a DEXA as part of their assessment. Just a couple of points to finish on. One is that the risk factors that are in FRAX are independent of bone density, but they're not completely independent of bone density. So if a patient is at high risk on the basis of non-BMD risk factors, the likelihood is that they will have low underlying bone density. And of course we carry around in our minds that our clinical trials are done in patients with low bone mineral density. That's where the efficacy sits most comfortably. And this is just an example of that. Here's the 10-year probability in an elderly female population in Sheffield. As we go down the column here, the probability, 10-year probability is getting bigger. We've put in a sort of conceptual intervention threshold here. But the point is that as the probability of fracture is increasing without measuring bone density, the underlying bone density is actually getting lower because some of the risk factors interact with BMD. BMI is a classical example. Low BMI, low BMD by and large. So the question then arises, if it's identifying low BMD, that's great. We think our drugs should work in patients at high risk. But what's the evidence base for that? Do the drugs work in patients at high risk? And this is a study, I really show this study as an example because this study didn't select the patients on the basis of bone mineral density. So this is a study that we did in Sheffield back in the late 1990s. We recruited 5,500 women over the age of 75 from the general community living in Sheffield. We just wrote to them and said, we'd like to do a study of risk factors for hip fracture. Oh, and by the way, we'd like you to take part in a 3-year double-blind placebo-controlled trial of a drug that you may not need. And we got 5,500 people to do that. And only 20% of them, we got a very good healthy selection bias. You know, all the healthy 75-year-olds and 80-year-olds came along to take part in the trial. Only 20% of them were osteoporotic at the hip when we measured them. This is the overall effect of the treatment in this unselected population. It decreased the risk of osteoporotic fracture by about 24%. And then if we look at the interaction between the efficacy and the white line of the treatment with fracture probability, you actually see that at low fracture probabilities, there's not much effective treatment. All of this is driven by the fact that at high fracture probabilities, the drug has most of its effect. So patients who are identified at high risk respond to the treatments that we've got because of the underlying low BMD and other things. And we've shown that same efficacy in moderate to high-risk patients with denosumab, basodoxifene, fluoxetine, and strontium riboside. So I'm just going to summarize there. So FRAX is out there. Welcome to FRAX for Greece, which is great. The use of FRAX, I think, is steadily going to move us away from a direction where all of our decisions are based on BMD. That's the way we've all done it up until this point in time, and that's the way that many of us will still continue to do it for several years, I would suspect. But we're actually going to move away from those sorts of approaches to actually treating absolute risk. Patients at highest risk get treated, patients at low risk, despite certain characteristics, will get managed, but not treated, will get followed up. It's alive, FRAX is alive, we're continuing to develop it. We continue to add new models to it, and we hope soon to add new variables to it, or at least tools that allow you to tinker with the probabilities based on other information that you have. Women identified to be at risk respond to the treatment. And the key is the final bit here, that this is a tool not just for clinical use, this is a tool for education. So it's time to reach out, not just to publish the guidelines, and I think you've done a superb job to get the guidelines together. A superb job. The hardest part is implementing the guideline, and it's really great to see so many of you here tonight to take away that message and to get the guideline out into clinical practice, and we're going to hear much more about the clinical guidelines in a second or two. Thank you very much for your attention.